שתלווה, תתמשך לאחר מכן בפאנל שניהל על ידי דוקטור גולדשטיין. אני אעבור לאנגלית לטובת המרצה האורח שלנו, שהתעורר מאוד מוקדם בביתו. Dr. Heyer, welcome to our meeting. Thank you very much for agreeing to be with us here so early in your morning. Dr. Heyer is a very well-known retina specialist. He's one of the leaders all over the world. He's the co-president and medical director of the Vitro Retina Service and director of retina research at the Ophthalmic Consultants of Boston, one of the largest and most prestigious multi-specialty ophthalmology clinics in the United States. But this is not all. Dr. Heyer is on the executive board of the Retina Society, the executive committee of the American Society of Retina Specialists, and the past president of the New England Ophthalmological Society and a member of the Macula Society. This is not enough. He is one of the leading retinal clinical researchers in the country for new treatments in neovascular and non-neovascular macular degeneration, diabetic macular edema, venous occlusive disease, vitreoretinal surgical techniques and instrumentation, as well as diagnostic imaging of the retina. He is a scientific advisor to many biotechnical and pharmaceutical companies, lectures all over the world, actually, and also in the United States, and has authored numerous, too many to count, peer-reviewed studies. He is always a member of the most prestigious advisory boards all over the world and across pharmaceutical companies. He will talk to us today about a very hot topic, a new coming up drug approved by the FDA, brolucizumab, emphasizing the efficacy and at the same time the safety concerns around it. His talk will be followed by a panel discussion which will be led by Dr. Michael Goldstein and will include the most prominent leaders in retina in Israel, Professor Joseph Musayev and Dr. Rita Ehrlich. I am sure that we will all benefit greatly from the talk and from the discussion on this controversial topic of safety versus efficacy issues in upcoming new modalities of treatments in our patients. Thank you very much, Jeff, for agreeing to be with us today.
On behalf of the brolucizumab Safety Review Committee, I will be presenting our report of intraocular inflammation, vasculitis, and retinal occlusions in Hawk and Harrier. In addition to the process, I will share with you over the next 10 minutes our findings in analysis of brolucizumab-associated inflammation. This lecture is sponsored by Novartis. My financial disclosures are shown here. I do serve as a scientific advisor to Novartis. The Safety Review Committee was supported by Novartis, but the analysis and findings were independent. In October of 2019, brolucizumab received FDA approval. Shortly thereafter, ASRS members began to report inflammation following brolucizumab use. In addition to mild inflammation, there were reports of vasculitis and occlusive vasculitis. The Safety Review Committee was established to provide an independent assessment of post-marketing cases and subsequently Hawk and Harrier cases to determine if a new safety signal existed and to help clinicians better determine the benefit-risk analysis of brolucizumab use. The committee was composed of global retina, uveitis, and imaging experts. It included members of 2 data monitoring committees and an observer from the ASRS. And the members of the Safety Review Committee are listed here. The SRC was first established in early March after these reports to both Novartis and the ASRS. The SRC involved independent case review and a series of web-based meetings over roughly 6 weeks. Cases were reviewed in depth, and the classification, severity, and visual impact of cases was determined. 60 brolucizumab cases were selected for review by the SRC. These cases were reported by investigators that had any type or degree of inflammation. They were categorized into those definitely drug-related, those probably drug-related, and those that were not related. As a rule, the SRC was inclusive. Cases were considered to be drug-related unless there was overwhelming evidence to not include them. This included several cases in which the imaging was inadequate to accurately determine a relationship. In such cases, these were considered probably related. Nearly 50% of cases were definitely related, another 37% were probably related, and roughly 17% were deemed not related. Many of these cases were obvious, as in this patient with arterial occlusions and cotton wool spots. In some cases, they were not obvious, as in this patient who was noted to have subtle vasculitis after careful review. We had a group of super reviewers who spent hours poring over these images to detect subtle findings of vasculitis and occlusive disease, such as that seen here. In many of these patients, vision was significantly impacted, as seen here. But again, in many, there were not, as in this patient who had plaques and arteritis nasal to the macula. The 2-year incidence of inflammatory events are seen here. The inflammation did not change much from our report as that initially reported by Novartis, as we were evaluating patients who had investigator-reported inflammation. However, the rate of vasculitis, which was 3%, and vascular occlusion, which was 2%, did rise. If patients had inflammation, vasculitis, or occlusive disease, their rate of moderate vision loss was 16, 22, or 30%, as shown here. If patients had inflammation, vasculitis, or occlusive disease, their rate of severe vision loss was 10%, 14%, or 22%, respectively. The 2-year incidence of inflammatory events and vision loss is shown here. Of moderate vision loss, it was 0.7 to 0.6%, and of moderate vision loss, it was 0.5%. For patients with inflammation, vasculitis, or occlusive disease. The timing of inflammatory events is shown here. Nearly 50% of all events occurred in the first 3 months, 74% within the first 6 months, and the large majority within the first 12 months. Of note, most vision loss occurred within the first 12 months. With respect to aflibercept, the overall incidence of inflammation in these patients was 1.1%. Only one patient had vasculitis and occlusive disease. Overall rates of vision loss, moderate or severe, are shown here. And of note, these events were similar between brolucizumab and aflibercept. As a result of these findings, several actions were taken to inform physicians and patients of this new safety signal. These included label updates, which were approved by both the FDA and EMA. In other actions, the label was changed to reflect that active intraocular inflammation, if present, should not be followed with an intraocular injection with brolucizumab, and the inflammation should be treated according to medical practice. In addition, a safety website, brolucizumab.info, was established, and SRC publications were prepared, and in fact, the main SRC publication has been accepted for publication. Here you see brolucizumab.info, the website that can give you updates on safety. These are the adverse event reports that you can find either on the Novartis website or the ASRS website, and we encourage you, or encourage all clinicians to fill out these websites as patients are seen, or if patients are seen, because these help the SRC, the think tank, and others follow these patients. As a result of these findings, Novartis has established a coalition whose job is to answer questions related to these adverse events. And this coalition consists of internal Novartis members in collaboration with top global experts to include clinical trialists, uveitis specialists, immunologists, and imaging experts. And the 4 key questions they're tackling are related to the root cause, patient characterization, mitigation, and treatment of these adverse events. Why are we so interested in continuing this process? Well, I hope these examples will help explain that. When brolucizumab was first approved, many of us had patients who had persistent fluid, such as this patient, who had been treated regularly with bevacizumab, ranibizumab, and aflibercept, and we were interested in seeing the effect of brolucizumab. And so in my clinic, I had a number of patients that I switched early on. And here you see the patient following the brolucizumab injection with resolution of fluid. This was another such patient with persistent fluid despite bevacizumab and aflibercept. And so you can see following the brolucizumab injection, there's resolution of fluid. Now, in my case, with these reports, I switched the majority of patients off brolucizumab as I became more aware of the severity of these reports. And here you see this patient developed the fluid again despite high dose aflibercept. In summary, the SRC found that the observed incidences of both retinal vasculitis and vascular occlusion were higher than those reported by the study investigators. In addition, the inflammatory events occurred more frequently in the first 6 months following the first dose, and the earlier events were associated more frequently with moderate or severe vision loss. Of note still, overall, the vision loss was similar between brolucizumab and aflibercept patients at week 96 of the study. I want to thank the organizers for the opportunity to share this report with you, and I want to thank the Safety Review Committee and Novartis for allowing this work to continue and everybody's tremendous efforts. Thank you.
Thank you very much, Dr. Heyer, who is joining us live from Boston, both for your captivating presentation and for waking up so early for us. I would also like to introduce our panel here in the studio, Professor Joseph Moiseyev and Dr. Rita Ehrlich, and of course, Professor Anat Lowenstein and Dr. Avi Ochayon. Yossi, I would like to ask you, if we had the brolucizumab in Israel, we don't yet, but if we had the brolucizumab in Israel, would you use it?
As I have no personal experience with the drug, what I'm going to say is actually my personal interpretation of the information that is publicly available on brolucizumab. And my summary is as follows. Brolucizumab is a new drug which has been shown to be non-inferior to aflibercept, maybe achieving the same results with 1 or 2 injections less per year, which is an advantage, but a minor advantage. And it comes with a serious safety issue, which is that several people that are receiving this drug are actually blinded by the drug. And the big question is, how serious is this complication? And I looked yesterday at this site of brolucizumab info, which sums up actually 12 months of information. And if you look at the bottom line of the data, it shows you that about 5.1 events of blindness will occur in 10,000 injections. Now, 10,000 injections in AMD would probably be anywhere between 1,000 or 1,500 patients. So that means that about 5% of 1,000, which is 0.5%, will be blinded by the treatment. So in my opinion, when I weigh the advantages, which is reducing the number of injections and burden by 1 or 2 injections a year, and on the other side of the equation is blinding 5 people out of my 1,000 patients, I would say that at this time, I would postpone using brolucizumab until I used all other agents. And even then, considering the prevalence of women, because it's more than 80% of the cases occurred in women, I would definitely pray that the patient which fails and needs brolucizumab is a man. So, that's my opinion.
Dr. Heyer, I would like to emphasize on Professor Moisev's words. The visual acuity results were similar between both brolucizumab groups and the aflibercept group. However, when you look only at those patients who did develop the intraocular inflammation, there was about 16% cases of moderate visual loss and about 10%, I think, of severe visual loss. And if it was coupled with artery occlusion, the rates were even higher, up to 21, I think, % of severe visual loss. So in this era of having 3 alternatives, 3 anti-VEGF, which have a significantly lower rate of adverse events, do you think we should take that risk with the new drug?
Yeah, I completely agree with your comments. So to me, the advantage of brolucizumab is more the anatomic benefits and the potential efficacy than the durability. Durability is helpful for treatment burden, but there are patients who we haven't seen respond with our current agents, respond with Brolu. But the concerns over the safety are real and important. And actually, I stopped all of my patients except one once we became more aware of these concerns. So until we understand it better, and at the academy, the recent academy, I presented data related to anti-drug antibodies and neutralizing antibodies that may give us more insight into these patients and may enable us to better understand who's at risk. Until that data is better understood, I'm not treating new patients with brolucizumab. I do have about 30 to 40 study patients who are using or in brolucizumab studies, and those patients are anywhere from 9 to 18 months out of study initiation. I've had the same discussion with those patients. Many of those patients have done extremely well, especially in studies that involve hard to treat patients, patients who were unresponsive to other drugs or suboptimally responsive. And virtually none of these patients wanted to switch off the study treatment. But we know the risk is greatest in the first 6 to 9 to 12 months. These patients were all past that risk.
So in the real life, if you decide to start on the brolucizumab with a naive patient, would you follow him, her differently in the first months? Would you see them like a week after the injection just to see there's no evidence or any signs of inflammation that just starts? Because we know that if there is some degree of inflammation, then having another injection may decrease or aggravate significally the symptoms. So do you see them more often? Do you tell them to come back with any blurriness in vision or to pay attention to certain signs or symptoms?
So I absolutely would. And again, to be clear, I've not been putting new patients on Brolu since we've understood these reports more. Mm-hmm. If I have patients who require Brolu, who have disease that is just not responsive to the current agents and the patients are losing vision, there are certain things I would make absolutely, I'd have to be positive of. One is that they don't have pre-existing intraocular inflammation or occlusive disease. That's clearly a risk factor. And these patients would have to be followed extremely carefully. I would see them, I would actually consider seeing them 1 or 2 days after the first injection and then a week after. And unlike many of our anti-VEGF injection patients who are not followed that carefully once we start treatment, many patients come in, we get a vision, an OCT, and we treat them. These patients have to be examined very, very carefully. I am somewhat encouraged by the data we've seen related to anti-drug antibodies and neutralizing antibodies, but even that will require a great deal of work and understanding to be able to figure out how to use that data in advance to try to prevent these events from occurring. And we still don't know if that will help us with the patients who get these events with the very first injection. Roughly 15% of patients had such an event with the very first injection.
Thank you. Rita, if we do have the brolucizumab in Israel, what do you think would be the cases that you would use them at the beginning of your practice with brolucizumab?
I think that because there is a real concern about the safety issues, I would only use them if I feel that the other drugs that we have that give us really good results. The problem is that we have good drugs that work really well, and brolucizumab doesn't work. It dries better the retina, and it was very exciting to see that result. But the safety issue is a real concern, and I think that if the concern is that he will lose his vision more from the disease than I think from the drug, I would probably try using that. And we do have patients that don't respond to any of the treatment, and there's a real concern about their vision, and sometimes they lose vision. I think they should have a drug that might help them better in drying them better.
Anat, would you like to elaborate more on that? Let's say you have a patient that has already been treated with aflibercept, ranibizumab priorly, and he still has a quite good vision of, like, let's say 630, 2100, but he does have persistent or recurrent fluid. Would you consider switching him to the brolucizumab?
So if I would consider, it's in a patient like this.
Yeah.
At this point, I would not consider using brolucizumab even when we have it in Israel in cases that are naive. It's exactly like you said, Jeff, and also for naive, or also for patients who are previously treated, I would need a really resistant patient to consider brolucizumab with, and I really look forward to see the proofs for the biomarkers that can tell us who are the patients that will react with inflammation. So definitely not a patient that has an autoimmune disease, definitely not a patient that had a prior uveitic response, because also some other anti-VEGF agents cause a little bit of uveitic response in some patients. So definitely not them, maybe not women, not Asian. Correct me if I'm wrong, Jeff.
We are in Asia.
East,
yes.
Far Asian. Correct me if I'm wrong, Jeff. I think this was also a risk factor. So I wouldn't, in these patients, I definitely would not. In a very resistant patient that doesn't respond, and I see the visual acuity deteriorating, after explanation of the risks and the benefits, I would maybe consider, in these very difficult cases.
Yeah, and that, to your point, there was a higher incidence in Japanese patients. Interestingly enough, with the multivariate analysis and looking more at the ADAs and neutralizing antibodies, that seemed to remove gender as a risk factor.
Oh, really? Okay.
And maybe just to conclude, I'd like to ask you a more theoretical question. As we have now multiple treatments, which all of them result in quite good visual acuity, do you think we should aim for developing a drug now that has a better visual acuity outcome? Or the more important thing would be to develop drugs which have a longer durability, such as maybe the brolucizumab or the PDS, which will allow injection every 6 months, which will eventually increase the compliance of the patient and maybe even the final results. So what do you think our efforts should aim in?
Well, certainly the real-world evidence has shown us that durability is important. The real-world results are frequently far less than what we've seen with phase 3 clinical trials where we have regular therapy. So treatment durability is important, and as you noted, drugs that may last longer, brolucizumab, drugs like faricimab, which is a bispecific antibody. There are gene therapy programs that are now ongoing that have significant potential, and the port delivery system had good phase 3 results. So durability is important. We'd love to be able to impact efficacy. That has certainly proven to be challenging, and we'll have to see with drugs like faricimab and maybe drugs that have other mechanisms of action beyond just anti-VEGF therapy, whether we can improve upon efficacy at all. Durability seems to be a very achievable outcome and one that would be highly meaningful to our patients.
Can I ask,
Thank you.
Can
Yes,
I ask
of course,
a short
Anat.
question? I would like to ask both the three of you, and maybe also you. For me, it's a little bit surprising. How come we got so far without knowing that this risk exists? I mean, there is a data safety and monitoring committee, there is the FDA, there is us, the investigators of the trials. With previous trials, with previous drugs, I remember, Michaela, you stopped recruiting for a certain study with another drug because of events. We didn't do all that, and the FDA and the data safety and monitoring committee. How come we didn't pay attention to all this? Maybe Yossi, Rita, and then Jeff.
Yeah, well, you know, sometimes when you have a patient and you're doing a CT or an MRI, the result comes normal, nothing abnormal found. And then the patient continues to have the disease, and a couple of months later they do another MRI and they see something, and then they go back to the first one and they see that it was already there. So I think probably the data monitoring committee did its job, we'd say, on a regular basis, on a standard level. But once the suspicion arises, you look more carefully. You probably look more in the periphery of the efflorescence, or you interpret things a little bit differently, and then you are smarter. But it took you time, and it's in retrospect. So I think it's a human problem, not so much a scientific problem.
Rita, and then maybe Jeff will tell us what it is.
I think everything is about the numbers. So if you don't see a patient that has a very remarkable decrease in vision and he has small symptoms, maybe you just ignore that, and maybe you then in follow-up, you observe it a little better and you start seeing the signs that you probably missed at the first place. So I think it's because of everything is about the numbers.
I completely agree. And, you know, as being the PI in so many trials, it's really the matter of how you report the adverse events. And in many cases, you do report it as a mild, moderate, but not as a serious adverse event. So the others investigators don't see it simultaneously. It takes months until we get the report. And by then, you don't put that much of importance to that specific adverse events. And I think at the end, as Yossi just mentioned, it takes time to realize that these are really very important adverse events.
Let's hear from Jeff. You're on all the committees ever.
Those reasons are exactly right. And you have to realize the data monitoring committee, they often get not so much individual cases, but they get groups of patients' outcome. And the vision loss was essentially identical for both moderate and severe vision loss between aflibercept-treated arms and brolucizumab-treated arms. The Safety Review Committee was really set up to look at post-marketing cases. When we saw those signals, we insisted on going back and looking at Hawk and Harrier, and that's when we started to find these other events. And it took reviewers, what I called the super reviewers, they would spend hours looking at these images, and they'd find small signs of vasculitis and occlusive disease that had not been noted. To be fair, most of those patients didn't have vision loss, or many of them did not have vision loss, but that's how we began to appreciate it. And to Novartis's credit, they're actually going back and looking at all the patients in the studies. So you're looking at, well over 1,000 patients in the different Brolu arms, as well as looking at the aflibercept patients to see if there are other cases of inflammation that may be there but weren't visually significant.
Thank you. Thank you.
All right, I want to thank the distinguished panel for being here and thank Dr. Heyer for a fascinating lecture on a very important topic nowadays and for waking up so early for us to participate in this discussion.
Thank you. Thank you very much.
Anat has done it for us many times.
That's true.
We meet very early in the morning recently.
Thank you very much.
We do, or very late at night.
Right.
Thank you, have a nice weekend. אני רוצה גם להודות לכל המרצים שטרחו והכינו מצגות כל כך טובות, מעמיקות ומעניינות, למודרטורים והפאנליסטים על ההכנה מאחורי הקלעים, הדיון המרתק וכמובן ההגעה הפיזית של כולכם שלא מובנת מאליה בימינו, שתרמה להצלחת הסימפוזיון הזה. את הכנס תוכלו למצוא אונליין באתר האיגוד למי שפספס או רוצה לראות שוב. אני רוצה להודות לחברת ההפקה שלנו קומטק על המקצועיות הבלתי מתפשרת להרמת הכנס הזה. תודה לכל החברות שתמכו, בזכותן העמדנו את הכנס, בייר, לפידות, אלרגן אבי, נוברטיס, ראש, טרדיסגט, מדי פישר וסרמדיק. תודה ענקית ומיוחדת לאביב אסקת מהמחלקה שלנו על ההשקעה והעבודה הקשה מאחורי הקלעים, ביחד עם דוקטור גולדשטיין ופרופסור לפשטיין המדהימים, ותודה לכם הצופים בבית שהייתם איתנו היום, ונקווה ששנה הבאה ניפגש שוב באיכילוב פנים מול פנים לתוכנית עשירה ומעניינת. שיהיה סוף שבוע נעים לכולכם.
ותודה לך, אבי. תודה רבה.